So as Zoe said, I'm a senior research advisor at Malaria Consortium here in London. It's an international NGO. It's not just focusing on malaria, and it's not a consortium, but nevertheless, we are doing quite a bit of work on disease control, technical support to countries, and research. I'm also an associate professor of health systems research and policy at Karolinska Institute in Stockholm. And I was asked to come and talk a little bit about the next steps of what can be added to verbal autopsy, and to really understand more the barriers to healthcare and risky behaviours and missed opportunities for health interventions. And this is what kind of comes under the umbrella term of social autopsy. I'm going to focus this talk on trying to define what social autopsy means, what methodologies and tools are currently in use, go through some of the results from studies that we have done, and talk a bit about challenges and limitations to these methods, as well as opportunities. So while we know, and what we've heard this morning is that it's the knowledge around the biological causes of death are critical, and they're obviously really, really important to understand what's happening in a society, but the additional information around barriers and failures that happen at household, community, and health system level are equally important to especially if we want to try to improve health programs that are delivering essential interventions. And the delivery of child survival interventions in particular really depend on the understanding of what the modifiable factors are that could improve the uptake or utilization of these programs. And those factors could be anything from social, cultural, or health systems related. So back in 1996, I think it was, over 20 years ago, there was a basics program under USAID that came up with this pathway to survival framework to investigate where kind of children and people fall off the pathway to survival, and try to estimate the relative contribution of barriers happening at home with recognizing illness. This was particularly focusing on child deaths. Care given at home, and then care seeking happening outside the home, the sources of care provided, referral patterns, compliance with care given and treatments given, etc., to really try to put the deaths into get a better picture of where children fall off this pathway to survival. So in relation to this, there were tools developed, and this is where the term social autopsy was first used, that then try to estimate or include questions around these different steps in the pathway to get a better picture of where these modifiable factors could be that could improve the programs. So since then, there's been a number of papers in the peer-reviewed literature looking at or investigating deaths from a more contextual perspective, social perspective. And they either do it by looking at specific age groups, neonates, children, maternal deaths, or they do it for certain disease conditions. And they often start from a verbal autopsy and then move into the study of the healthcare seeking process that preceded the death. And the terminology that's been used has ranged from death narratives, confidential inquiries, expanded VA, death audits, but more commonly nowadays, it's the terminology used is social autopsy. And whether that's appropriate or not, we can probably debate later. So anyway, in 2007, I moved down to Uganda, and I worked in one of the in-depth network sites in Iganga district. And it's one of the sites which started using verbal autopsy very early on for applying this to all deaths. It's an area with 67 communities. And also, very early on, we attached social autopsy to all these deaths that were investigated through verbal autopsy. And we used these tools that were developed about 20 years ago. And when we started looking at this data, we found that they weren't really up to standards. They weren't suitable necessarily for a context where now newborn deaths were contributing more to the under 5 mortality. And we also found that there was a lot of inconsistencies in the tools that had been used. These were developed a long time ago, so we felt that there was a need to really kind of review all the tools that had been around, and we weren't also able to really compare our data with other studies and countries that had used other tools. So based on, or out of a grant that we got from the In-Depth Network, we set up a social autopsy working group to try to standardize the tools that were used for this purpose. So it was a 3-year effort where we were a group of researchers from 4 different in-depth network sites in Africa. And we got together and systematically reviewed all the tools that had been utilized and kind of debated the content of the different tools. And we came up with 2 tools, one which was specifically for newborn deaths and one which was for under 5 deaths, excluding the newborn period. And we took these tools back to the 4 in-depth sites, and which was Bandim in Guinea-Bissau, Dodowa in Ghana, Iganga Mayuge in Uganda, and in Kilifi in Kenya. So they were tested over a year in these 4 sites, and we came back, we reviewed the data collected, and refined the tools further based on the results we found. And then eventually we came up with 2 tools that were considered kind of standardized for in-depth network sites who wants to use them, and they are now sitting on the in-depth website for use in any of the 49 sites. I think it's 49 today, for use to be added to verbal autopsy when found suitable or when needed. So the tools we developed were again paper-based. They were quite lengthy, lots of skip patterns, etc. So last year, under a grant that we had at Malaria Consortium, this was before we had the MIVA, before we had any other kind of mobile phone tool. So we developed our own ComCare base. It's ODK based, but using ComCare. So we developed our own mobile phone tool to be able to investigate deaths in one of the provinces in Mozambique where we worked. So the tool had a verbal autopsy component following the WHO standardized tool at the time. This was 2014, so it's probably outdated by now. And then we added a mobile phone version of the social autopsy tool to this. And we were interested in looking at deaths happening in one province in Mozambique where we had a well-functioning community health worker program, where community health workers were delivering anything from first aid to treatment for malaria, pneumonia, diarrhea, malnutrition, and doing newborn follow-ups. So it was specifically with a research question on why do children die when we have community health workers in their communities. So this tool, we also used the InterVA, which was the kind of computer software at the time to analyze the cause of death from the verbal autopsy. And then the social autopsy tool here was applied to those deaths that were acute and where the patient had died kind of within a short time span of illness. We also, as part of the going back to this in-depth network social autopsy working group, as part of that exercise, we developed kind of standardized analytical tools. It's a very simple Excel-based analysis toolkit to try to come up with some standard variables for how to analyze social autopsy data, which can be otherwise quite messy. There are loads of indicators. It's really difficult to know where to start. So in this analysis toolkit, it has basically one column with yellow shaded cells that can be entered where certain information, like it follows this pathway to survival framework. So it looks at proportion of children whose illness was recognized at an early stage at home, children, and what kind of treatment was given at home. It looks at care-seeking patterns and providers used and so on. So it calculates automatically the proportion of deaths that kind of fall under each category. And one of the, the other component of this analytical toolkit is a section that looks at the 3 delay model. So here we're looking at the proportional contribution of delays happening at the home in transit to a healthcare provider or at the health provider. So each variable here is weighted to give an overall kind of proportional contribution to each type of delay that happened during the care-seeking process that led to death. So one of the outputs, for example, that this toolkit gives is a pie chart, very simple. It's all kind of not very complicated, but it is still quite useful to just get an overview of, in the deaths that happened in this community, what proportion had the severe delays happening at home, how many had delays en route to the health facility and in the health facility. And another output that is generated automatically from filling in these yellow cells is to a populated kind of pathway to survival. So here, you can't read it, but it's giving the proportion of deaths that kind of went outside for care, who stayed home and never went outside for care, who went to a formal provider, informal provider, etc. And this table is specifically now, or this diagram shows the data from our Mozambique research. And just wanted to highlight two numbers. What we found was quite interesting is that the majority of children were actually recognized quite early on by a caregiver that they had a mild or moderate illness. So 86% stated symptoms that indicated that the child was sick before it got really like showing severe symptoms. But still 16% of these children never made it outside the home and didn't even get treatment at home before they died. And about 77% did seek outside care. And when we asked that specific question on why do children die when there are agentes polivalentes elementares, which is the Portuguese word for community health worker, and we found that utilization of these was really low in the children who died. Only 23% of those who had gone outside had actually been taken to a community health worker, which is interesting because the informal providers in this community, there's not a big private sector. And so the majority would still then resort to very remote health facilities or hospitals. But also what we found was that of those who went to a community health worker, only 44% actually got treatment from them. And that could be either due to, we knew there were stockouts during this time period, but it could also be that the children, we looked at acute illness, but it could have been an acute illness that couldn't actually be treated by the community health worker. But it gave us some interesting data on how low uptake is of these community health workers, even when they're trained and equipped and available in the communities. So we've only really scratched on the surface of this data. I think there's loads of more analysis we can do, but I'm just giving you some headline results. And then showing what we can find out from looking at these simple pie charts is, this is now looking at the 3 delays of children who died in Uganda, Mozambique, and Ghana. And what I find quite interesting is that it really varies a lot by context and country where these delays take place. And obviously the delays are huge risk factors for the illness then leading to death. So in Uganda, we found that the majority of delays actually happen when the child has reached the health provider. Whereas in Ghana, most of the delays happen at home. Whereas in Mozambique, you see that there was almost an equal contribution of delays happening at home and at the health provider. So these are all deaths happening in the same age group, but due to the different health systems, you see that the proportion of deaths, the delays that happen are very different. So when we unpack this a little bit more, we looked at pneumonia-specific deaths in Uganda. And this is another way to apply social autopsies, to not just look at one age group, but to actually look at one cause of death. And indeed, it kind of backs up these results that the deaths, a lot of the children actually reaches the health provider, and then they die. So half of the pneumonia deaths in this demographic surveillance site in Uganda, they actually died at hospital, and 1/3 of them died at home. And the illness duration was quite short. They died of pneumonia from after the illness was recognized, the cough was recognized. They died within 7 days. And they only took approximately 2 days before they sought outside care from the cough, which is actually quite short. However, a lot of people gave home treatment, and half of them gave antimalarials, which could have delayed the care-seeking process. Obviously, we know malaria and pneumonia have very similar symptoms, so it's not always easy for the caregiver to decide which treatment to go for if they use the private sector, which they very often do in Uganda. But 27% of these children who died of pneumonia, according to the verbal autopsy, had taken antibiotics before dying. And obviously, when this is obtained from the private sector, we don't know the quality, the quantity, the duration. So there could be a lot of mistreatment going on, irrational use. But still, most of the children were taken for care outside the home before dying, and 36% actually went to a public hospital first, and they bypassed community health worker, they bypassed the low-level health facilities and went to hospitals. But still, 1/3 of those who reached the district hospitals were referred onwards because the district hospital couldn't deal with them. And they either died on the way during the referral process, or they simply couldn't afford going to the regional hospital. And also we found that 90% reported, only 19% reportedly improved after having been seen and treated at hospital. So this, just to show you that social autopsy data can actually give you much better kind of in-depth picture of what happens in the health system when a patient dies. So some of the challenges and limitation with this methodology, though, is that care-seeking patterns are very rarely like a linear pattern. It often includes a diverse mix of treatments, starting from herbal treatment at home, going to a drug shop, or getting some drugs from the neighbor. And then also it involves a range of providers. So social autopsy may actually simplify this a bit too much sometimes. Current tools only look at the first source of care and the last source of care because it's just simply too complex to try to analyze every single source of care sought, and it would make the tool very lengthy. And as a result, the current tools are really only suitable for acute illnesses where there are a few providers involved, and it wouldn't really be possible, I think, at the current stage to use them for chronic conditions or long-term illnesses where there's kind of a lot of different providers involved during a longer period of time. So also, the current social autopsy tools do not take into account also other factors that we know have a big influence on mortality, including household decision makers, social capital, and we have seen in Ethiopia, there's a lot of research showing that social capital and social networks are actually hugely, they're influencing mortality to a very large extent. So, and also, lastly, a very important limitation is by design, because we're only looking at children who die, we can't actually determine the association between those risk factors and the death. So that would require then a case control kind of design if we wanted to look at that. But it can still give a good overview of the kind of the patterns in the society. So just to wrap up, some of the opportunities that can be seen is that it is fairly easy to add social autopsy to a sample of verbal autopsy. It doesn't have to be applied every single time, but it can be done on a sample of, for example, if you're interested in a certain cause of death or a certain age group, it can be applied, and it's often useful, we found that, to do the verbal autopsy first and then perhaps go back and analyze that data and then come back to the family later to do the social autopsy. And this information can be really important for health planners to understand where and why people die, and to prioritize the scarce resources to kind of target interventions where they're most needed. And it could also be a potentially promising tool to investigate maternal mortality. We didn't get that far in our in-depth working group, but I wanted to quickly just show a really interesting study from India by Källander and his research team, where they not only used social autopsy on maternal deaths, but they used it as a community mobilization tool by going through this 6-step process where they ask the community to report the deaths, they sensitize them, they do the social autopsy on these deaths, they analyze the data, and they go back to the communities to discuss the results and ask the communities to come up with locally relevant solutions on how to address maternal mortality. And they involve the local governments to support these local solutions. So it's another way of then utilizing the data in a way that to kind of improve programming. So in conclusion, I think it's really important to understand not only what people die from, but why they die. And social autopsy can be a useful method to improve this understanding. And I'm happy to see that it is being added now to the verbal autopsy tool to some extent. And we do see from our evidence that social autopsy can really reveal these important delays that contribute to death and how they differ by context and country and age groups. So my last conclusion is probably not necessary anymore, that social autopsy in some form should be added to verbal autopsy when possible. So I'm really happy that that seems to already be happening. Thank you.